Hi, everyone. I'm Carli Friedman, the Director of Research for the Council on Quality of Leadership, also known as CQL. Also presenting with me today is Chester Finn, who is an advocate at the New York Office for People with Developmental Disabilities, also known as OPWDD. Today, we'll be talking about ableism, racism, and intersectionality and their implications for healthcare. This slide features a Black man in a wheelchair being pushed by an Asian man, while a white woman walks alongside them. Before we get started, I just wanted to acknowledge the WITH Foundation who provided funding for this project. And this slide features a picture of the WITH logo, which has hands that look like a bird. So the word intersectionality gets thrown a lot these days, but what does it mean? Well, intersectionality is a framework coined by Kimberly Crenshaw to help us recognize and understand how different forms of oppression overlap, intersect, and interact, affecting multiply marginalized people based on their identities. So usually when we think about or look at discrimination, we think about one identity at a time, like disability, race, or gender, and not and. Treating people as one monolithic group who all have the same experiences and identities. This is called single access. It's kind of a binary or siloed approach, and it doesn't consider that people have many identities and also that discrimination isn't isolated like this, but overlaps and intersects, hence the name. And discrimination isn't necessarily additive either. So it's not like we can just jump to the conclusion that disabled women experience more discrimination because of being both women and having disabilities. They might, but you don't necessarily just add it together like this. They often face unique forms of discrimination. For example, Crenshaw talks about how Black women often experience discrimination that is unique to not only their race or gender, but the combination of their race and gender, differing from the experiences of Black men and white women. And this slide has a magnifying glass. I know I'm talking kind of theoretical, but here's a good way to think about it, your classic Venn diagram. When you combine multiple colors, the shades don't just darken, but actually turn into brand new colors. So blue and yellow together make green, red and blue together make purple, red and yellow make orange. Now, all three colors also create kind of brown. Now, this is a very simplified example, and things don't always work this cleanly. And like I mentioned, it's not necessarily an additive effect like this. But this is what I mean when I say people with multiply marginalized identities can experience distinct forms of oppression and discrimination. Sure, when combined, these colors may be related. So to go back to the example from Crenshaw, Black women can experience racism in the same or similar ways as Black men, or sexism in the same or similar ways to other women, but they also can experience it in ways that are distinct to the fact that they are Black and women. Compared to other identities, there's been a lack of attention to disability when it comes to intersectionality. Disability identity and ableism often have been treated as single access, where it's assumed that all disabled people have the same experiences regardless of their other identities. Yet disability at its core is intersectional, as it not only cross-cuts every other identity group, but also is inseparably shaped by racism, white supremacy, and other oppressions.
Too hot outside.
This slide has a picture of a group of friends standing on a boardwalk and taking a selfie. There's a long history of race and disability being intertwined. For example, physician John Langston Down created Down syndrome to mark differences in presentations of what at the time used to be called idiocy, according to racial and ethnic stereotypes such as Mongolian idiots, because of what he saw as a likeness to Mongolians. He believed that people with Down syndrome's physical characteristics or their personalities fell outside the norm of what one should be as a white European, while simultaneously suggesting that racial differences in and of themselves represent disability. For example, he once noted, quote, "The boy's aspect is such that it is difficult to realize he is the child of Europeans, but so frequently are these characteristics presented that there can be no doubt that these ethnic features are the result of degeneration." Basically, the early conceptions of Down syndrome incorporated both ableism and racism. And autism is another example. Psychiatrists and psychologists first thought that only white children could be autistic. For years, they thought it was literally impossible for children of color to be autistic. Similarly, Asperger's syndrome, which has been since recategorized as autism by the DSM, explored and upheld ideas of racial purity in Nazi Germany. These are not just behind us either. Even today, race can shape how disability is not only understood, but also how disabled people are treated. For example, in school, Black children with disabilities are punished, restrained, and arrested at significantly higher rates than non-Black students. In addition, racism, such as environmental racism, colonialism, and police violence, also create and cause disability. Labeling people of color, whether or not they have disabilities, as disabled has also been used to reinforce racism. And many races and ethnicities have been deemed disabled because their genetics are supposedly inferior. There are plenty of other examples like this, and these examples are by no means exhaustive, but they show the long history of disability and race intersecting. Despite this, disability is often treated as race neutral, with much research implying disabled people have monolithic experiences with less disability research focusing on multiply marginalized people. Yet intersectionality recognizes that systems of oppression not only interact, but are also inseparable. But less attention has been drawn to intersectionality and ableism, especially related to racism. Doing so is necessary not only to better understand how oppression impacts disabled people, but also to ultimately reduce the harmful impacts of discrimination. In addition to there being less attention on intersectionality, another problem is we haven't always had good ways to measure intersectionality beyond qualitative research. For example, implicit association tests, or IATs, are one of the most prominent measures of implicit or unconscious attitudes, with millions of people taking them for education or research purposes. IATs have two binary groups, such as black or white, men versus women, disabled versus non-disabled, on each side of the screen, and then compare participants' reaction times when categories align and conflict with stereotypes. Despite much research finding IATs to be valid and reliable, one major drawback of IATs is that the standard IAT, regardless of its focus, only allows single axis comparisons that focus on a single identity at a time. Not only do oppressions intersect, as I mentioned, but single axis attitudes are also not as neutral as they're often thought. For example, a study by Goff and Kahn found that when you ask someone to picture a person experiencing racism, they almost always picture a Black man. When they asked people to imagine someone experiencing sexism, the person imagined was almost always a white woman. So even when told to focus on a single category, people often think of other intersecting identities. So basically, the Disability Attitudes Implicit Association Test, or the DAIAT, when it presents people with disabled and non-disabled, people are probably thinking about particular races, likely white ones. Attention to intersectionality is necessary not only to truly understand how discrimination operates, but also to strengthen validity of research about these processes. Due to the ways that disability and race overlap, intersect, and inform each other, in order to dismantle ableism or racism, we must first understand how these processes operate, including when it comes to implicit bias. For these reasons, the aim of this study that I'm going to talk about was to develop and establish a new intersectional way to measure implicit attitudes called the Intersecting Disability and Race Attitudes Implicit Association Test, or the IDRA-IAT for short. I piloted the IDRA-IAT with 536 people in the general population across the United States. 28% were non-disabled white people, 32% were disabled white people, 13% were non-disabled people of color, and 27% were disabled people of color. This slide features an Asian man with Down syndrome sitting at a desk. Unlike traditional IATs that are binary, like disabled versus non-disabled, white versus black, women versus men, the IDRA included 4 identities: non-disabled white people, disabled white people, non-disabled people of color, and disabled people of color. While participating, participants sorted pictures of people with these 4 identities, along with different words related to good and bad. Their reaction time was measured for different combinations of items to determine implicit attitudes. This slide has examples of people from those groups, including a non-disabled white man, a white man with Down syndrome, an Indian non-disabled woman, and an Asian woman with Down syndrome. Single-axis IATs from millions of people indicate people have moderate levels of bias against disabled people and moderate levels of bias against people of color. While findings from this study did indicate people have bias against disabled people and people of color, the patterns of that bias differed significantly depending on if the disabled people were white or if the people of color were disabled. The findings from the IDRA IAT indicated people preferred non-disabled white people the most with a mean of 0.19, then disabled white people with a mean of 0.04, then non-disabled people of color with a mean of negative 0.09, and then disabled people of color with a mean of negative 0.13. Across all participants, while disability did play a role in attitudes, it was really whiteness that was prioritized most, regardless of disability, with white, non-disabled, and disabled people receiving the most favorable implicit attitudes. This slide shows the direct comparisons between each of the groups. Despite research indicating how prevalent single-axis ableism is, disabled white people were preferred over non-disabled people of color and disabled people of color by the majority of participants. This nuance, which often goes undiscovered in single-axis IATs, reinforces the need for intersectional implicit measures. Equity for disabled people means not only reckoning with ableism, but also racism. In addition, when I compared by each participant's own identities, there were significant differences in implicit attitudes depending on people's identities. This graph shows differences by participant identities, and in the next slides, we'll untangle the different lines. So this is non-disabled white people. They favored themselves over all others, and then their fellow... Chester, would you mind muting yourself, please? Thank you. So they favored themselves over all others, and then their fellow disabled white people having the most negative attitudes for disabled people of color. While this finding is perhaps not unexpected, it does highlight what information is often missing in single-axis studies that just focus on ableism broadly, which would portray this group as having bias against disability, but not showing that most of this bias appears to stem from attitudes towards disabled people of color specifically. There appears to be some in-group race favoritism in play when it comes to their attitudes towards disabled white people. Even though this finding may not be unexpected, it is important given this population is where the most bias intervention is needed, since they had the highest levels of bias, coupled with the fact that this group often has the most power compared to the others. Disabled white people significantly favored their own racial identity or in-group compared to their own disability identity or in-group, preferring themselves and non-disabled white people significantly more than disabled people of color. It may be that disabled white people leverage, perhaps knowingly or unknowingly, their white privilege to distance themselves from the effects of ableism. While this may serve as a protective factor in some cases, such as the fact that disabled white people were viewed more favorably than disabled people of color in the study, this comes at the expense of solidarity with disabled people of color. Also, unlike participants from the three other identities, white disabled participants in the study were the only ones to say that they had equal preferences for all of the four groups explicitly or consciously, saying that they did not prefer any of the groups over any of the others. So not only did disabled white people underestimate how much they implicitly favored white people, but they also underestimated how much bias they had against people of color, whether they were disabled or non-disabled. In contrast, while non-disabled participants of color implicitly favored non-disabled white people the most, like the other participants, they preferred disabled white people and disabled people of color to similar degrees to each other and to themselves. So it was only when white non-disabled was the reference group that they had the lower level of preference for the other three groups, suggesting some internalization of society's ideas about social norms. However, the fact that non-disabled people of color had similar attitudes towards themselves as non-disabled people, as both disabled people of color and white disabled people, could be indicative of different boundaries of what disability is and means among people of color, especially given the racialized nature of disability. While their favoritism across the four groups ranged less than the participants from other identities, findings from disabled participants of color suggested internalization of racism, given they favored white, non-disabled, and disabled people the most, although the latter to a slightly lesser degree, including more than other non-disabled people of color and themselves. Research about disabled people of color has been mixed, with some finding them to have stronger disability identities and more disability pride, and other research finding disabled people of color have more internalized stigma and weaker disability identities. These findings may be because disabled people of color, due to living at the intersection of disability and race, have different experiences of discrimination, and experiences with oppression accumulate, having a wearing it down effect, which in turn results in internalization of these attitudes, stereotypes, and biases. In addition to these findings, the analyses also found the IDRA-IAT had sufficient reliability and validity. So now that the tool was established, the aim was to use it to further explore how intersecting attitudes work to ultimately improve these attitudes. An Asian girl with Down syndrome smiles at the camera in front of a chalkboard while another Asian woman stands behind her on the slide. For example, disabled people, including people with intellectual and developmental disabilities or IDD, experience numerous health disparities which are largely avoidable and due to inequities. Healthcare professionals' biases impact the quality of their care and, by extensions, the outcomes of their patient. For example, healthcare professionals are not only less likely to refer people with IDD to preventative services, they're also less likely to offer interventions and provide people with IDD lower quality care in general. One large problem is many healthcare professionals lack knowledge about disability and thus make assumptions and can be informed by stereotypes. For example, many healthcare professionals assume people with IDD are less likely to feel pain, are burdens, and have a lower quality of life. The assumptions healthcare professionals make, which are largely driven by stereotypes, also result in providing lower quality of care. Research even finds do not resuscitate or DNR orders are more frequently placed on people with IDD without their or their family members' consent. So in this case, biases can be deadly. Because of this, and to improve health equity, we must reduce healthcare professionals' biases. Better understanding how these attitudes work is a critical first step in doing so. That's why in the next part of this project, I had 784 healthcare professionals complete the IDRA-AAT as well as measures of explicit attitudes. There were more than 75 healthcare occupations represented from a wide range of professions such as nursing, direct support, mental and behavioral health, rehabilitation and therapy, general medicine, and other allied health professions and medical specialties. On this slide is a picture of an operating room. In one of my past studies of 25,000 healthcare professionals, we found 84% of healthcare professionals were implicitly biased against disability. Yet in this study, healthcare professionals preferred disabled white people over disabled people of color when the two were directly compared. The findings from the IDRA-IAT also indicated healthcare professionals preferred non-disabled white people with a mean of 0.18, then disabled white people with a mean of 0.08, then disabled people of color, a mean of negative 0.12, and then non-disabled people of color with a mean of 0.14, although there wasn't a significant difference between their attitudes about non-disabled and disabled people of color. So 61% of healthcare professionals had positive implicit attitudes about disabled white people, compared to only 34% of healthcare professionals having positive implicit attitudes about disabled people of color. Again, proximity to whiteness was prioritized and seen as more favorable, regardless of disability status. Not only can their biases impact the quality of healthcare professionals provide, but people that experience discrimination from healthcare professionals are also more likely to have worse mental health, participate in unhealthy coping behaviors, and to further delay and forgo future care, all of which further hinders their health. Also particularly interesting was the difference between healthcare professionals' explicit and implicit attitudes. Explicitly or consciously, healthcare professionals believed, or at least expressed, due to not wanting to be judged, that they preferred non-disabled people and disabled people of color the most, and reported favoring non-disabled white people the least. However, healthcare professionals' implicit attitudes were almost exactly opposite, favoring non-disabled white people the most and non-disabled and disabled people of color the least. These findings suggest that either healthcare professionals are not aware of the true extent of their implicit attitudes, or they were overcompensating and going out of their way to indicate that they were either neutral or like disabled people of color. Therefore, according to the findings of the study, healthcare professionals may not be aware of the full extent of their biases and, by extension, the different ways that they may treat or serve people. In fact, in this next study, I examined how healthcare professionals' intersecting attitudes can impact the beliefs and stereotypes they have about people with IDD. On this slide, a woman wearing scrubs speaks to a person who lays on an exam table. While doing so, I found significant relationship between healthcare professionals' intersectional implicit attitudes and their beliefs about people with IDD being more difficult patients, being more likely to exhibit challenging behaviors, and having a lower quality of life. However, the patterns of these associations frequently differed, not only based on implicit attitudes towards disability, but also race. In this study, the more healthcare professionals implicitly favored non-disabled white people and non-disabled people of color, and the less they favored disabled white people and disabled people of color, the more likely they were to think people with IDD are more difficult patients in healthcare. In addition, while all four identities were significant, implicit attitudes towards disabled people of color resulted in the largest impact, suggesting that this may be particularly strong when it comes to disabled people of color. Unfortunately, once patients are labeled as quote unquote difficult, healthcare professionals provide them lower quality of care, treat them less effectively, have worse communication with them, and discharge them more frequently. This likely contributes to the disparities in health and healthcare people with IDD, especially people of color with IDD, experience. This slide has examples of people from these groups, including a non-disabled white man, a white man with Down syndrome, an Indian non-disabled woman, and an Asian woman with Down syndrome, as well as arrows indicating the relationships I just described. When healthcare professionals in the study had better implicit attitudes about disabled white people and disabled people of color, they were less likely to believe that people with IDD exhibit challenging behaviors. Just like difficult patients, challenging behavior is another relatively subjective concept that is often applied to people with IDD. While people with IDD may be more likely to participate in maladaptive behavior, which causes harm to themselves or others, what is considered challenging is subjective, and rather than this being something wrong with them, this behavior is frequently a form of communication, with the cause often environmental and social. For example, untreated medical conditions, experiencing abuse and neglect, untreated trauma, and experiencing discrimination can all lead people with IDD to participating in this behavior. Racism also influences healthcare professionals' perceptions of people's behavior, with people of color being overdiagnosed and misdiagnosed with psychiatric disabilities and perceived to have worse behavior. As a consequence, people with challenging behavior are then more likely to be restrained and secluded, prescribed psychotropic medications, often without mental health diagnoses, and institutionalized. However, as indicated by the findings, professionals' implicit biases may influence what behavior they deem challenging. This may result in a self-fulfilling prophecy where the ways they treat people with IDD causes people with IDD more discomfort, anxiety, and stress, which they then express through their behavior, which the professional then attributes to the person's disabilities or character rather than environmental causes. Thus, it's important for healthcare professionals to recognize the ways that their own behaviors, preconceptions, and attitudes may actually contribute to the behaviors of people with IDD, as well as explore environmental causes of this behavior like social determinants of health. And this slide features the same people I just described in the last slide. There was also a relationship between healthcare professionals' implicit attitudes and their perceptions of people with IDD's quality of life. So previous research has found clinicians to assume people with IDD and disabled people in general have a worse quality of life. However, one important component unearthed in this study was that there was not a relationship between healthcare professionals' implicit attitudes about white disabled people and their beliefs about people with IDD's quality of life. Instead, It was how much they preferred non-disabled white people, as well as their attitudes about disabled people of color. Specifically, that was associated with different assumptions about quality of life, with worse attitudes about disabled people of color being associated with presumptions about lower quality of life among people with IDD more broadly. So ableist stereotypes about the quality of life of people with IDD are likely implicitly informed by and rely on racist stereotypes. These assumptions about quality of life may also obscure the fact that disability itself does not hinder quality of life, but instead quality of life is hindered by the ableism and racism people with IDD experience. Also problematic is that the perceptions about quality of life play an important role in treatment decisions, triage, medical rationing, and end-of-life care, which, as seen during the early phases of the COVID-19 pandemic, can all have a deadly impact for the disability community and people of color. And this slide features the same people I just described in the previous slides. Another interesting finding was that the majority of healthcare professionals, or 80%, agreed with the statement, quote, "At work, I treat people with IDD equally to non-disabled people," while only 10% disagreed and 10.4% were neutral. However, this is self-report and their perceptions of their behavior and attitudes. Remember earlier how their conscious attitudes were very different from their unconscious ones, with most people preferring white non-disabled people over disabled white people and disabled people of color. Plus, we know from decades of research that people with IDD, especially people of color with IDD, face disparities in health outcomes and quality of care. Therefore, the question is not really if healthcare professionals treat people with IDD equally, but rather why did almost all perceive themselves as doing so? How could their misunderstandings of the extent of their attitudes impact the quality of the services and supports they provide? And how could it impact people with IDD's outcomes? Next, we'll hear from Chester about this. I've been speaking rather theoretically and analytically, but Chester is going to bring us back to the real world and to talk about how this can actually play out on the ground. And this slide has a picture of a young Latina girl with IDD hugging her mom. Please take it away, Chester.
Oh, okay. I know when I first heard the presentation and we were going over this, it was a lot of surprising things because I didn't think that, I knew from what I saw, in life and the advocates and the people with disabilities that I interacted with, that it was, a lot of, differences in, discrimination and things like that. I had experienced some differences when I went to meetings at the White House, and we were talking at the time about the closure of sheltered workshops, where some other organizations with people with disabilities thought that people with intellectual and developmental disabilities should have workshops because they felt that um, if they didn't have an intellectual or developmental disabilities, that, they didn't need that they could communicate in the community without it, and I felt that wasn't good because, at the time we were trying to organize to see whether we needed to shut down workshops and that everyone should work and that the community altogether should see that people with disabilities could work and, add to, the workforce. So, that was surprising. Of course, I wanted to jump over the table at the person from the other organization, disability organization, because actually, it was uh, the blind community, someone representing the blind community. And I'm like, look, I have uh, developmental disabilities as well as, being a person with a visual impairment that, how could they have those thoughts? They should be supporting us and, not saying that, they have it better than us, but, to show you that, like your study was saying, that there's discrimination everywhere, even amongst us with disabilities. we have differences, but we should be working together to show the whole community that we all have lives and we have things, that's important to us. I like the part about when you talked about healthcare professionals. A lot of times they don't separate, you know, the differences of people. They look at us as sick, people that, are in the hospital that's sick, that needs, care, or you don't need care. If you don't cooperate sometimes with them, they'll think that you're a difficult patient or whatever. I know before when I was in the hospital with eye infection and some of the other patients that came in, they didn't have disabilities, but we networked and kind of got along and supported each other. So I think that supporting and understanding each other is so important because you have to, get along with people. And I think a lot of it is people getting to know you and you getting to know them. Because if they don't experience who you are and the things that you have to deal with, then they don't know that and understand that. I think part of it is we as a community of people with disabilities, we kind of separate ourselves because we have uh, the thought of, okay, uh, IDD over here, mental health, um, people that neurodiverse, and all of these things. We usually fight for those things and not what we can do and how we can, work together in the community to educate people that, people with disabilities are the same as, people in the community. We just should, work harder together on things. And I think that um, it shows in some of the research that you've done and in your study that's important. One of the things that'll be important to do is to make those things available to people with disabilities in the groups. And I know in some of our self-advocacy groups, it would be important to let people know that we can have an impact on the community and that working with people to show them, in their lives, some of the things and some of the thoughts that they have about other people, or you might not think that, you have differences with people. I can tell you as far as, you know, using sports as an example, I and my friends and the people in our neighborhood used to well, cheer for the Lakers because of Magic Johnson, and my friends were cheering for Boston because of Larry Bird. We didn't think nothing of, we thought about sports. But if you break it down, it was like we were cheering for Magic because he was in the, black community, and uh, the people were cheering for Bird because, he was a white guy. We don't think about things like that when it comes to things like sports, but people have those hidden thoughts, like the survey said, in their minds, and they never talk about it up front. But as the survey says, your actions speak louder than what your words could say, and that how you favor one group of people over the other people. And one of the things that I also notice is if you have people coming from a different country or speaking a different language, sometimes people treat them like um, they're special. Oh, you can do something so great. You don't speak English. We've had that in some of our schools or, colleges and things like that, instead of just treating people as people. Um, when I went to Japan, I didn't speak the language and they couldn't speak English, but we had some things in common, which I visited what they call a workshop, and it was different than ours. It was a bakery. And through the interpreter, the people were, the interpreter was telling me that they were coming, bringing me gifts, and they didn't look at, you know, what color I was. They looked at, where I was coming from. I was coming from the United States, but I was coming to help them fight for their rights and talk about people with disabilities in their country being equal. And I think that we should look at what things we have in common and how we can work together to build things rather than what we have to separate us or, tear us apart. Because I think um, for the most part, people with disabilities connect because we have something in common and we can relate to each other. I know that when someone calls me, or I know that people need different services, I can connect with them. And I think that a lot of times people connect with people what they have in common, what they can relate to with the other person, um, which is so important. I think we need that now more than ever because there's so many things that can divide us, money, social status, all of those things can divide us. But one thing that we do have in common is we want the same things. We want to be a part of the community. We want to have a house. You know, People want to get married, they want to have children, and they want to be successful in what they're doing. And I think that one of the things that we forget about is understanding each other and working with each other. The society today is like, oh, I don't know who they think they are. They can't tell me nothing. I do what I want to do. It's the me attitude opposed to we are working together or we can make changes together. And I think we forgot about that. And we forgot about we need each other to survive. That nobody can survive in this world just by themselves. And we don't think of what we can do for the other person, how we can support the other person. We always think about, well, you got yours, I got my, I'm going to get mine. And, you know, we're so caught up in the success, we forget about the things as, caring about other people. And I think uh, one of the things way back in time was we forgot about, love. We forgot about how to support each other, how to work with people. I know that I learned from my grandmother and my mother and father and my community how to be polite to people. Good morning, good afternoon, and all of those kind of things, polite words. At first, people would, I would say, good morning, how you doing? People would look at you, the day is not so good. I didn't want to get up this morning. Or, those kind of things. Your attitude, what you can do can change people. Somebody might be having a bad day and you, good morning, with a smile, that changes their day because you don't know what that does for a person. It makes them feel different. And I think a lot of times with those surveys shows us who we are, what we are, and what we need to change and how we need to change. I think we're so afraid to do that. We're so afraid to talk about it. We're so afraid to reach out to people and say, well, can I help you? Is there anything that I can do? You know, we're so caught up in tearing people down, we forget how to build people up, how to support each other. And I think that, Carli, in the studies that they did and the research shows you who we are and what we can do and how we can support. I mean, there's a lot of stuff that was alarming in the study, but I think it's there to show us what we need to do and how we need to do it. How we need to support each other. I think a lot of times we don't like to be told that we're wrong about something or that we need to change and we need to do something different. But I think that, you know, the research will help. I was excited about the research to find out, what's really happening, but what is my part? What is our part in changing it, making a difference? We know these things are out there, but I always look at it as what can we do to change things? How can we make things different? How can we work with people? Just because people say things about people, you don't know them until you get to understand who they are and where they're coming from, what your attitudes are, and that I believe that we can change things. We have it in our hands to do so. A lot of times we wait for other people to do it, but I'm a person that's like, what can I do? How can I make a difference? How can I change things? And if we have that attitude, I think we can go a long way in changing the world and making it different. It's not too late. And if you look at those surveys and you look at those studies that Carli has presented to you, you will have some insight to who you are and where you came from. But also, I think the point is what we can do, how we can make changes, and how we can be able to, you know, head off things before they happen.
Thank you, Chester.
Yeah.
So this slide features a white man with IDD hugging a black man. So given the inequities disabled people, people of color, and especially disabled people of color face, addressing ableism, racism, and their intersections in healthcare is critical. Given the biases uncovered in these studies and which as Chester just talked about, intervention for healthcare professionals' implicit attitudes is needed. Many healthcare professionals get little to no education about disability, especially from an intersectional approach. As such, I believe it would be beneficial for healthcare professionals to receive more education, especially education that's informed by disability justice and discrit, which is a combination of disability studies and critical race theory, to address the intersection between racism and ableism and help dispel assumptions and stereotypes about disability, such as related to assumptions about quality of life. While education and practices are beneficial starting points, they alone will not address the role implicit attitudes can play in informing healthcare professionals' perceptions and behavior. We must improve healthcare professionals' implicit attitudes about disabled people, especially disabled people of color. Yet there's a lack of interventions which have successfully improved people's implicit attitudes, especially healthcare professionals' attitudes. As such, more research is needed to examine not only the ways that implicit attitudes operate, but also how to successfully intervene in these attitudes long term. This research must be intersectional, especially given these findings about how bias operated differently based on disability and race. The more we understand how biases work, the better equipped we are to improve these attitudes. Intersectionality must be a cornerstone of doing so. Until we eradicate these biases will continue to threaten the health and quality of life of people with IDD and disabled people more broadly. We have several free resources about this project on our website, including the published journal article and some plain language videos about these studies at c-q-l.org/intersectionality, or there's a QR code on the screen that links you to this page. And this slide has a screenshot of the journal article as well as the plain language videos. In addition, since learning about our attitudes is an important step in improving them, on our website, you can also find a link to take an intersectional IAT yourself and find out more about the implicit attitudes you may have. And the website is c-q-l.org/IDRA. And on the slide, a disabled woman of color sits in a wheelchair and looks at her phone. This slide has a picture of a phone with the CQL website on it. Some of the studies are still under review at journals. If you're interested in reading about them when they come out, they'll be announced on our listserv, which you can sign up for on our website, as well as our social media accounts on Facebook and LinkedIn. And the slide has hands holding up a hashtag. Our emails are cfriedman@thecouncil.org and chester.finn@opwdd.ny.gov if you want to reach out. We'll also now take some questions as time allows. So first, we have a comment in the chat box saying education is key to learning and understanding each other. Completely agree. Thank you. And then the next is a question that says, has there been any additional research into best practices, the best ways to counteract this seemingly unconscious implicit bias in healthcare workers? Is there any evidence that direct education and person-centered practices and approach help with this? So as I mentioned, there's been a little bit of research looking at how to improve attitudes, and unfortunately, implicit attitudes are particularly difficult to improve because they are unconscious. So it's hard to change your attitudes if you don't realize the extent of the attitudes that you have. I will say though, learning more about our attitudes is always beneficial and a great way to, work to improve our attitudes. The more we know, like the person that just commented, the better equipped we are to kind of make those changes. In terms of the person-centered aspect of your question, I think that's a great point because not only person-centeredness puts the person at the center of their services and their lives, but it's also a reframing about how we think about disability, right? So traditionally, we've thought about disability as, we need to take care of these people and do everything for them, which is a really problematic and biased way of thinking about disability and understanding disability. But person-centeredness really kind of flips that on its head about respect and listening to the person and recognizing that every person has value. So I do think even though there's not been formal research on how that improves attitudes, there has been formal research on how that improves quality of life. So by extension, I'd say those changes that in how you think about disability would also be really beneficial in attitudes about how you think about race and disability together. So the next is a question for you, Chester. It says, how have you pushed back against this kind of bias and self-advocated, especially in a healthcare setting? Have you ever had to have direct conversations with providers about this?
Yes.
Can you
I
talk?
um
Sorry, go ahead.
I talk to my doctors and healthcare workers all the time. They get to know who I am. So, you know, they treat me like they would any of their other patients, and we have conversations. And, I tell them if something that I need, let me know. And if something that you're doing that I don't feel comfortable with and I don't like, I will let you know. And also at the beginning of it, it's like it comes down to it. Who has to sign for them to get paid? They have to, I'm the patient. So if the patient don't sign or the patient don't agree, then, you know, they can't give the care or they can't get the stuff that, you know, they need. And don't just assume that I need something, and I bring support people to help me get to the doctor's office. But when it's going in to the doctor, I have the doctor talk to me. And then if I need somebody to come in with me, I have to be free to do that too. So you have to speak. You have to open the mouth that you have to advocate with, or if you have people to help, that helps.
Thank you, Chester. So the next question is, what would you recommend in terms of top three strategies to mandate training for medical providers? I typically don't believe in mandates, but we have been trying to move the needle on educating providers on the better part of 2 decades. What are your thoughts? Yeah, I I would agree with you. I don't know. I think uh, certainly we need more education, and I think it's important that that education is not just based in disability, but as we've seen, should be kind of taking an intersectional approach. And for that, I would strongly recommend it kind of be oriented towards disability justice, which is all about intersectionality and also kind of being led by the people most impacted, such as disabled people of color, and recognizing, that disabled people are whole and kind of focusing on interdependence instead of independence, as well as the combination of disability studies and critical race theory, which tries to move us away from those single access approaches that I talked about, where it's kind of centering and privileging white disabled people. Um, I mean, maybe that's asking for a lot, but I think we got to set the bar high, and it's certainly clear that when healthcare professionals don't know a lot about disability, they just make assumptions that are largely based in ableism and racism. And the problem is the way that implicit bias works is we really internalize a lot of society's attitudes, because we're constantly receiving messages from society about disability and race. And so if we don't have that proper education to kind of counteract those messages, then it's our understandings of disability and race and disabled people of color is going to be largely informed by just kind of those stereotypes that we've taken in. So I think that education would be really beneficial. The next question is, do you think language is a help with biases? Maybe I'll say a little bit about this, and then Chester, if you want to comment as well. So I actually have done some research about disability language, and I think language really does help shape the ways that we see the world. So certainly it plays a big role in either reinforcing biases or helping to change them. If we're using problematic language, some of which has a long history with oppression and discrimination. I'm thinking like the R word and some kind of clinical labels that were applied to people with IDD were literally used to justify, sterilization, institutionalization, segregation. So we're not only calling on that history, but we're reinforcing problematic things about disability when we use that type of language. Chester, do you want to add anything about
Uh,
language and
yes, I think now we in the disability community is encouraging people to use, plain language, language that everybody can understand and relate to. And just because you know big words and can say big words and understand them doesn't mean that, you know, you don't know anything or know less. And I think it's hard to get people to understand that, like you said, Carly, the R word. The R word to me is just as bad as the N word and some of the other words that you use because you're not building people up, you're tearing them down. And if you know what's right, no matter if it's your family or your friends or whatever, you're supposed to let them know. Whenever I have friends or family members and they use something that's not appropriate for people, I let them know that it hurts people and it's discriminatory towards people. So you got to do your part too. You just can't wait for other people to do it. You know, you have an obligation as a person.
So our next question is, how do you think people that are less or have not visible disabilities impact implicit attitudes in comparison to those with more visible disabilities? Do you feel like your graphs would look different or the same if it was explicitly differentiating those types of disabilities? I will say that some of the pictures I showed you, it was just to kind of keep consistent with the pictures I showed you, but the iDraw IAT, I did have it was across disability, so there was lots of different disabilities represented, although people obviously that have invisible disabilities, it's a little bit harder to kind of represent that in a photograph. So that is, certainly one of the limitations and opportunities for future study and future research. But there is research indicating that people with less visible disabilities some experience discrimination, but in different ways. So sometimes, for example, they might be able to, pass and not be seen as disabled, but also sometimes their experiences can be invalidated because of their invisible disabilities. Chester, I don't know if you wanted to say anything
I
about visible
I
versus,
think
yeah.
I think that's so important because sometimes people don't tell you, or I have friends that don't want to tell people or don't want people to know unless they have, you know, a cane or, some kind of device to say that they have a disability. And, you know, we're insensitive sometimes to people. Oh, what are you doing there? I might have some of my friends with me and we might be going places or we're at a mall or something, and then people will say, oh, that's so nice. You're helping him. And my friends will say, I'm not helping him. We're just friends. I'm assisting him with what he needs. You know, if I need something, I'm sure that, and he can help me, he would do that. So it's not an act of kindness to be, that you're helping this poor, pitiful person. It's, you know, because you want to. And I think it's harder for people that have, hidden disabilities because it's not something that's visible, something that you can see. I mean, it's in certain times, and I know a lot of people are going to say, why you say that? I'm glad that there's a lot of stuff that I don't see. I might not see it with my eyes, but you can feel it and see it with your heart.
Thank you. We do have more questions and comments, but unfortunately we're out of time. If you wouldn't mind, just really quickly, we have a quick little poll to just gauge how much you learned or how much you like this webinar, and then we'll end after you respond to this. Thank you so much for all your time.